diabetic emergencies, but here we are going to talk about the thyroid emergency and adrenal emergencies. So this is the quick look about anatomy of the thyroid. It consists of two loops. It is in front of the neck, connected by the isthmus, supplied by the superior thyroid artery and the inferior thyroid artery. We can see that in the blood, the iodine and the sodium importers are there, which passes through the basal surface of the thyrocytes to the thyrocytes, and then from the thyrocytes to the colloid by the pendrin molecule, pendrin transport. Here in the colloid, that iodine got connected with the tyrosine amino acid and thyroglobulin, and then this formed the monoiodo tyrosine and diiodotyrosine, which after coupling from T3 and T4, those hormones got endocytosis and then transported back to the blood by MCT. So quick look about the thyroid gland. It secrete most of the hormone is T4 in the form of T4, which is not the active hormone. The active hormone is T3, which is basically formed in the periphery by the peripheral conversion of T4 to T3. So there is a feedback mechanism which started from the hypothalamus, which secrete TRH, which stimulate the TSH from the anterior pituitary, and that TSH act on the thyroid gland, which secretes T3 and T4 hormone. This negatively affect the pituitary and the hypothalamus. So in cases of primary hypothyroidism, like in where the gland itself secretes less hormone, less T4 hormone, it causes negative feedback and it start increasing the TSH and TRH. Similarly, in the primary hypothyroidism, the gland secretes most of the FT4 and the TSH secretion diminished. So what is thyrotoxicosis? Thyrotoxicosis is a state of excessive thyroid hormone. It doesn't tell that the gland is actively producing the extra hormone, or it is destroyed and the thyroid hormone released at once, or the person has consumed a lot of thyroid medicines. So thyrotoxicosis is a general term which says excessive thyroid hormone in the body, and hyperthyroidism means excessive hormone production from the thyroid gland. If at any particular time the thyroid gland destroyed completely, it can maintain up to 30 to 60 days. There is a term called apathetic hyperthyroidism, particularly in elderly. It typically features the marked and patient present with fatigue and weight loss. Mostly they present with AF, atrial fibrillation. So causes of sustained hormone production can be classified by radioactive iodine uptake and TSH level. So low TSH and high RAIU. RAIU, like the radioiodine uptake is increased in the thyroid gland. So the common causes are Graves' disease, toxic multinodular goiter, toxic adenomas, low TSH and low RAIU, like thyroiditis. Here the gland is destroyed, so they don't take the uptake. Struma ovari and normal with elevated TSH, like TSH secreting pituitary tumor. They are very least common causes. So these are the causes of primary hyperthyroidism, like Graves, toxic multinodular goiter, toxic adenoma, functioning thyroid C8 metastasis, struma ovari. Thyrotoxicosis without hyperthyroidism, like thyroiditis and thyrotoxicosis factitia. Secondary hyperthyroidism, like TSH secreting adenomas. So by viewing what is the systemic effect of the increase in the thyroid hormone, it increases the heart rate, it decreases the peripheral resistance, so the pulse pressure becomes wide, there is a loud S1, and we can listen a systolic murmur at the left side of the body. It is called Means-Lerman scratch. It can have mitral valve prolapse associated with this and atrial fibrillation. Metabolic effects, it both increases the synthesis and degradation of protein, but the protein degradation is affected more, so patient become weak. Pre-existing diabetes can aggravate. Lipogenesis and lipolysis both increase, and triglycerides slightly decreased. In the nervous system, patient has emotional liability, hyperkinesia, nervousness, attention deficit in the children, fine tremors in the hands and tongue, and proximal myopathy, which is mostly in the males, and periodic paralysis. Graves' disease is associated with 3 to 5% cases of myasthenia gravis. Skin will be warm and moist. Palmar erythema can be there. Elbow is smooth and pink. Hair will be fine and friable. Plumber's nail. The oncolysis will be there, especially of the fourth and fifth finger. In the alimentary system, there can be pseudo-diarrhea, hepatic dysfunction, hepatomegaly, jaundice, and liver failure. In the hematopoietic system, person can present with RBC increased mass, pernicious anemia, increase in the decrease in the TLC count with increase in the lymphocyte, monocyte, and eosinophil. Splenic enlargement, thymic, and lymph node enlargement can be found. Platelet count will be normal. Dose of warfarin to be reduced in cases of hyperthyroidism as the vitamin K dependent accelerated clearance. Factors का clearance fast. What are the other signs and symptoms? Other signs and symptoms are hyperactivity, irritability, dysphoria, heat intolerance, sweating, palpitations, fatigue, weakness, weight loss with increased appetite. There are only few causes of weight loss with increased appetite like diabetes, hyperthyroidism, and malabsorption syndrome, diarrhea and polyuria and oligomenorrhea, and loss of libido. Tachycardia, as we have discussed, atrial fibrillation, particularly in elderly, tremor, goiter, warm and moist skin, lid retraction and lid lag, especially in cases of Graves' disease and gynecomastia. This is a pictorial presentation. So, little bit about the Graves' disease. It is an autoimmune disease associated with HLA-DR2, 3, and B8. There is the serum IgG binds to the TSH receptor to stimulate the thyroid hormone production and symptoms of hyperthyroidism. Symptoms will be almost same, except that they are mostly associated with the ophthalmopathy, and the features as we know the mnemonic no specs. There is involvement of the lids, there is involvement of the periorbital muscles, and at last the optic atrophy can be there, and person may be blind. Dermopathy. Less than 5% patient of Graves' disease present with dermopathy. It is always associated with ophthalmopathy and pre-tibial myxedema. There is the increase in the thickness of the skin at the shin area. So this is a confusing statement, a pre-tibial myxedema, but it happens in the hyperthyroidism. It is a non-inflamed indurated plaque with deep pink and purple colored orange skin. Thyroid acropathy, it is a clubbing that is found in less than 1% of Graves' disease, strongly associated with ophthalmopathy. Clinical course, if it is not treated, it can be carry the mortality of 10 to 30%. Mild Graves' disease may be spontaneous remission. 30 to 60% remission occur in about 18 months with the treatment. So whenever you find a patient with decrease in the TSH, the patient who is not taking any medication but having low TSH, we have to differentiate Graves' disease and versus the thyroiditis. So we go for the radioactive iodine uptake. So in the above picture, you can see that there is a black spot bilaterally and in the middle. So these black spots are salivary glands, submandibular salivary glands, and the thyroid area, the area below that is not taking any uptake. So this is of thyroiditis. While in the below picture, you can see the thyroid gland take the whole of the iodine. So this is the Graves' disease. So they uptake the whole of the iodine such that even no salivary gland take any iodine. The thyroid gland is so much hyperactive that it concentrates all the iodine. So the above picture is suggestive of thyroiditis and the lower picture is suggestive of Graves' disease. The treatment comprises of antithyroid medication like carbimazole and thyroxine. Beta blocker also used for stopping the peripheral conversion of T4 to T3. Radioiodine uptake. Radioiodine is also a treatment of choice, and we have to know that treat with the antithyroid medicine for about 1 month, then stop for 3 to 4 days before radioiodine treatment. There is some comparison of propylthyroxine with carbimazole. The T-half is propylthyroxine is 90 minutes only, and carbimazole is 6 to 8 hours. Potency is higher of carbimazole 5 times. Transplacental activity is there for a carbimazole. There is no transplacental activity of propylthyroxine. That is why during the pregnancy we switch over from carbimazole to PTU. PTU is highly plasma protein binding and it inhibits the peripheral conversion too. What are the common side effects of ATD? These are the mild side effects like skin rash, arthralgia, abnormal taste, and sialadenitis. Granulocytis is the major side effect, but it occurs in less than 1% of the patient. It is associated with the fever and sore throat. Hepatitis, it can more associated with the propylthyroxine. Other rare complications are ANCA-positive vasculitis or polyarthritis. Radioiodine, it is the treatment of choice for those who are having toxic adenomas. The effect is it causes radiation. In late scenario, it can cause late hypothyroidism. It can cause radiation thyroiditis. It increases the chances of orbitopathy. So it is not a drug. It is not a treatment of choice in those Graves patients who are having ocular involvement. It is to be avoided in pregnancy. So choice of therapy depend upon the what is the age of the patient, what is the pregnancy status, what is the reproductive age group. So in those we take into account all these things when we prescribe the treatment of choice. A little bit about the thyroid storm. Definitely it is the high acute emergency of hyperthyroidism. Any patient who is having AF or PSVT or non-infectious causes of fever, weight loss or unexplained jaundice, that the thyroid storm should be ruled out. It is abrupt onset, incomplete treatment with ATT, precipitated by infection, trauma, and surgical emergencies. Symptoms are similar like fever, profuse sweating, sinus tachycardia with or without pulmonary edema, delirium, psychosis. There is a score called Bartovsky Bartovsky point scale. It comprises of temperature, CNS system effects, gastrointestinal or hepatic dysfunction, cardiovascular dysfunction, heart failure, and precipitant history. So if the total score is more than 45, it is highly suggestive of thyroid storm. And if it is less than 25, it is highly unlikely that it is thyroid storm. What investigation we will send? We will do the thyroid profile, CBC, which can show the leukocytosis, increase in the liver enzymes and bilirubin. It can show the hypocalcemia. We can check for cortisol because it can make the person deficient in cortisol, USG neck. What are the common differential diagnoses? Differential diagnoses are sympathomimetic agents. Sympathomimetic ingestion like heat exhaustion, heat stroke, pontine stroke, pheochromocytoma, delirium tremens, malignant hyperthermia, pregnant neuroleptic syndrome. Treatment usually preferred in the ICU with oxygen support and cardiac monitoring, fluid resuscitation, correcting electrolytes, and nutritional support. So goal is to inhibit the synthesis and release of the hormone. What we can give antithyroid medication like PTU because it is a short-acting one and it acts fast. So PTU is a drug of choice. During the thyroid storm, it can be given 300 to 400 milligram, 4 to 6 hourly by mouth or a Dial's tube. We have to stop the release also. We can use Lugol's iodine by 8 to 10 drops 8 hourly or easily available. Lugol's iodine is not easily available. So what we can use the radiographic contrast agents, which is easily available in the radiology. 1 gram TDS for 24 hours, then 0.5 gram twice a day. And lithium we can also use. Other treatment include dexamethasone, 8 mg TDS, propranolol, which inhibit the peripheral conversion, 40 to 80 milligrams 6 hourly. Cholestyramine, 4 grams 6 hourly, reduces the absorption of the thyroid hormones from the gut. We have to correct the dehydration and hyponatremia. And if there is a fever, we can use the cold blanket or ice packs. If the patient does not respond, we can use the plasmapheresis or hemoperfusion. So this is all about the thyroid storm. Now we will move to the second emergency that is called Myxedema Coma. So a little bit about the hypothyroidism followed by the Myxedema Coma. So hyperthyroidism is caused by congenital agenesis or defective hormone synthesis or autoimmune diseases like Hashimoto, atrophic thyroiditis, postpartum thyroiditis, or subacute thyroiditis. Post-surgery, post-radiation infiltration like tumors secondary to HPA axis like Sheehan syndrome, peripheral resistance to the thyroid hormone. In the autoimmune thyroiditis, the genetic predisposition is there like HLA-DR4 or CTLA4, and environmental factor also influences like iodine intake or Hashimoto thyroiditis. The pathophysiology is by the lymphocytic infiltration, follicle damage, and fibrosis. It may lead to the atrophic thyroiditis in the course. The main pathological thing is that TPO antibodies which destroyed the enzymes and TSH receptor antibodies. So we can see the various types of thyroiditis and its codes and classical features. The autoimmune thyroiditis is can be associated with other autoimmune conditions like vitiligo, pernicious anemia, type 1 diabetes, and alopecia. 5% of patients develop or thyroid ophthalmopathy. So thyroid ophthalmopathy can be a feature of Graves' disease and can be found in the autoimmune thyroiditis also. Hashimoto encephalopathy. Hashimoto encephalopathy is a close study of Myxedema Coma. It is a steroid responsive syndrome associated with TPO antibodies and myoclonus and slow wave activity on EEG. Postpartum thyroiditis, few words like it is a mostly autoimmune. It occurs mostly in the 3 to 6 months postpartum. It has a phases like hyperthyroidism followed by hypothyroidism, and ultimately euthyroidism. Uh, mostly the patients are ATP antibody positive and ESR is normal. Subacute thyroiditis, it is mostly post-infectious, also known as decurrent thyroiditis. Again, the same phases occur like hypo, and euthyroid. 15% can turn to the hypothyroidism. Look like URI. The patient will complain of the pain in the throat, and many times it mixed with the URI symptoms. ESR will be increased. Treatment is symptomatic with anacid and steroids. What are the common symptoms and signs? Tiredness, lethargy, dry and coarse skin. Where the hypothyroidism are moist and warm. Here it is hoarse and cool extremities, puffy face, hand and feet, feeling cold, menorrhagia, hair loss, diffuse alopecia, delayed relaxation of deep tendon reflexes, weight gain, peripheral edema. It is said that the weight gain is due to the mild fluid retention, and it is up to the 4 to 5 kg weight gain only. Carpal tunnel syndrome, paresthesias and dyspneas. Course-wise, bradycardia, it causes decrease in concentration and memory loss. And constipation, it increases the serous cavity effusion and hearing is impaired. How to treat? We have to replace as the person is deficient in the thyroid hormone, we have to replace by levothyroxine. The classical is 1.6 microgram per kg body weight per day. Titrate with the TSH only. If the person forget to take, next day they have to take the double the dose. Uh, Factors increases which needs the dose to be increased, like malabsorption or small bowel surgery or celiac disease. Medicines like iron, calcium supplementation, PPI, rifampicin, amiodarone, carbamazepine, and phenytoin, these all decreases the absorption and hinders the absorption. So either we should avoid to give along with these medicines, or we have to give more medicine. So Myxedema Coma is mostly occur in the elderly and precipitated by the factors that impair respiration like drugs, pneumonia, CHF, MI, GI bleed, or CVA, characterized by reduced level of consciousness, apathy, psychosis, and sometimes with seizures. Diastolic hypertension is there, and later it can be hypotension. So the nutshell of the Myxedema Coma is associated with the hypoventilation, a decrease in the response to hypoxia, and hypercapnia is noted. Infiltration of the tongue, pharynx can further cause respiratory abnormalities and sleep apnea. It also causes the diaphragmatic weakness. It is associated with hypothermia, hypoglycemia, or dilutional hyponatremia. Bladder dystonia and distension, paralytic ileus, megacolon, fecal impaction. The skin is, as we know, it is dry and cold. Non-pitting edema can be there. Puffiness, alopecia, and bradycardia. What is the closed DD? We have discussed that Hashimoto encephalopathy, ASCOPD. So those elderly patients who are coming with the increase in the CO2 and they don't have history of COPD, we should think about Myxedema Coma, especially in the winters. OHS, obesity, hypoventilation syndrome, CVA, meningitis, and hypothermia. What investigation when we think about this, so we can send TFT and CBC. CBC can reflect anemia or leukopenia. Increase in the CPK level, SGPT can be high, hyperlipidemia, and hypoglycemia. So you can see that Myxedema Coma is mostly associated with the hypoglycemia and the thyroid storm. In contrast, associated with the derange in the blood sugar level, it increases the blood sugar level mostly. So treatment mostly this patient need the ICU care. Correct the hypovolemia and electrolyte abnormalities, may need mechanical ventilation, vasopressin inotropes may be inotropes, and these inotropes can be arrhythmogenic in the hypothyroidism. Treatment of hypothermia have to be addressed. Use regular blankets, avoid warming blankets. So classically in the Myxedema Coma, when the body is too much deficient, we have to give IV thyroxine, but it is mostly not available in our country. So the dose is IV, it is 100 to 500 microgram stat followed by 75 to 100 microgram per day. But as the IV preparation is not available in our country, we used to give 200 to 300 milligram stat followed by 200, at least 100 or 150 daily. As the gut absorption is also reduced, orally we have to give a little bit more of the doses, and we can titrate it with the other things like heart rate and FT4 level. So lower dose is needed in the frail and elderly patients. Steroid we can give in hydrocot 100 mg thiazide if there is a clinical suspicion of adrenal insufficiency, because both can be autoimmune in nature. Identify and treat the precipitating event. So this is all about the thyroid emergencies. Now we will move a little bit about the adrenals. So adrenal, we have two things common in our day-to-day practice. One is when to think about adrenal crisis and when to think about Cushing's disease. Cushing's disease is generally present in the OPDs, but there are patients we encounter in our emergencies like COPD patients who are taking steroid one or the other reason and they present with this. So how to manage those patients, we will discuss a little bit about that. So anatomy and physiology, the cortex and the medulla. Adrenal has a cortex and the medulla. Cortex form the glucocorticoid. Main hormone is cortisol, mineralocorticoid, aldosterone, and androgen, DHEA, and androstenedione. Glucocorticoid promotes and inhibits the gene transcription in many cells and organ system. It has anti-inflammatory, increased hepatic gluconeogenesis, and mineralocorticoid regulate the electrolyte transport across epithelial surface, particularly renal conservations of sodium in exchange of potassium. Medulla has chromaffin cells which synthesize and secrete catecholamines, mainly epinephrine, and the lesser amount of norepinephrine. They are responsible for flight and fight response, the chronotropic, inotropic effect on heart, bronchodilation, peripheral and splanchnic vasoconstriction with skeletal muscle dilatation, glucogenolysis and lipolysis, and renin. So causes of hyperadrenalism. Primary, that is the gland itself destroyed, like by autoimmune diseases, tuberculosis, surgical removal, hemorrhages, infarction, especially by meningococcal infection, infiltration, or Shelder's disease like adrenal leukodystrophy. Corticosteroid biosynthetic defects or secondary hyperadrenalism. When the ACTH secretion is decreased, your adrenal become secreting less cortisol. So when we think about autoimmune, that the autoimmune primary hyperadrenalism is very common, and when we got autoimmune disease, we should think about polyglandular autoimmune diseases, that is PGA. So when we should think about hyperadrenalism, if the person is having weight loss and we are not getting anything, malaise, lethargy, fever, anorexia, nausea, vomiting, pain, abdomen, depression or confusion, impotence or amenorrhea, postural hypotension, pigmentation over the new scar or the palmar creases, loss of body hair. And along with this, if somebody is having hyponatremia and hyperkalemia, and along with this hypoglycemia, chances of adrenal hyperadrenalism is quite high. So you can see here that glucocorticoid deficiency causes fatigue, lack of energy, weight loss, fever, normochromic anemia, lymphocytosis, eosinophilia, hyponatremia, hypoglycemia, and low BP. Mineralocorticoid deficiency causes pain, abdomen, nausea, vomiting, salt craving, postural hypotension, hyponatremia, again, hyperkalemia, and increase in the creatinine. Adrenal androgen deficiency can cause lack of energy, dry and itchy skin, loss of libido, loss of axillary and the pubic hair. Others are hyperpigmentation in the primary adrenal deficiency due to excess of POMC-derived peptides, and it increases the pigmentation of the new scars. So how we can confirm this? So we can do the general things like CBC, KFT, and TFT, and blood glucose and cortisol 8 a.m. fasting we can do. If it is low, then it confirms your diagnosis. But if it is not low or intermediate, then we can do the stimulation test with the ACTH. If the value is less than 16 to 18 microgram per deciliter sampled after 60 minutes of ACTH administration, it confirms the diagnosis. Then to know it is a primary hypoadrenalism or secondary, we can do the ACTH level. Short selectin test is quite common when we discuss about the hypoadrenalism. We can give 250 microgram of ACTH given IM any day, any point of time in a day, and we measure the cortisol 0 to 30 minutes of cortisol. If there is a rise of more than 18 microgram per deciliter, it rules out the deficiency of uh, uh, cortisol. So as I have told you that it is acute adrenal insufficiency is present with shock and responsive to vasopressors, associated with hypoglycemia, hyponatremia, and hyperkalemia. Treatment is intravenous fluids, 2 to 3 liter as fast as possible, along with injection hydrocort, 100 milligram IVI stat, then followed by 6 hourly. And other treatment like mineralocorticoid, if the person is not responding to the glucocorticoid, and we can add the mineralocorticoid in the form of fluticort, 100 microgram per day. And if we need, if there is a concern of androgen deficiency, we can add those things also. But those things are typically not in the care of emergency, so I am skipping that. So let's move to the Cushing syndrome. So Cushing syndrome is primarily by the adrenal hyperplasia secondary to the ACTH overproduction, or by adrenal macronodular hyperplasia, adrenal hyperplasia, adrenal micronodular dysplasias, adrenal neoplasias, or exogenous like iatrogenic. So that is the most common causes secondary to the ACTH by the other carcinomas like ACTH or CRH producing carcinomas like bronchogenic carcinoma, carcinoid of thymus, pancreatic CA, or bronchial adenoma. So here is the table which can show that ACTH dependent Cushing's is 90% and ACTH independent Cushing's is only 10%. Male to female to male ratio is more in the Cushing's disease, that is ACTH dependent is 4:1. ACTH independent is also more in the females. You can see here that ectopic ACTH secretion is having equal sex ratio. So what we can by symptom, what we usually get: weight gain, central obesity, and round face. It is called buffalo hem. Facial plethora, thin brittle skin, easy bruising, broad and purple stria over abdomen, hyperpigmentation of knuckle, scars, and skin areas exposed to friction. It can cause proximal myopathy, hypertension, hypokalemia, edema, and atherosclerosis. Glucose intolerance, diabetes is become aggressive, and dyslipidemias, it can cause decreased libido and amenorrhea. In the CNS, it can cause the irritability and emotional liability, depression, cognitive defect, or psychosis. Increase suspension of infection, increase TLC and eosinophilia, and hypercognitive. So diagnosis is done by the 24-hour urinary free cortisol, that is if it is more than 50 microgram per deciliter. Serum cortisol 8 a.m. or 4 p.m. we can do, or midnight plasma cortisol more than 130 nanomole per liter. We can do the suppression test. We can give 1 milligram of the DEXA, and if the value of plasma cortisol is more than 2 microgram per deciliter, we can confirm the diagnosis. Again, we have to do the plasma ACTH whether to see whether it is ACTH dependent or independent. We can also do the urinary 17 ketosteroid and DHEAS level if we are thinking about the adrenal causes and thinking about the adrenal carcinoma. Further, we can need pituitary or abdominal CT. A little bit about the iatrogenic Cushing's syndrome, which we usually encounter in our day-to-day practice. The more common symptoms are increase in the IOP, intraocular pressure, cataract, benign intracranial hypertension, aseptic necrosis of femoral head, osteoporosis, or pancreatitis. More rare are the hypertension or oligomenorrhea. Treatment, medical treatment we can give by meteropone or aminoglutathione, ketoconazole, mitotane, or trilostane. Surgical, we have to take out the tumor from the pituitary, or if it is there in the adrenal, then we have to do bilateral adrenalectomy and radiation. Nelson syndrome is something which is when we do the bilateral adrenalectomy, that ACTH, if we wrongly do the bilateral adrenalectomy and the tumor was there in the pituitary, so the tumor become more aggressive after the adrenalectomy, then it is called Nelson syndrome. Recovery occurs best in the ectopic ACTH producing tumors, and lowest with the adrenal Cushing's, and intermediate with the Cushing's disease. So many times this Cushing disease is confused with the pseudo Cushing like alcohol, depression, and obesity. We have to take into account all the scenario in the picture. That is why it is very important to correlate clinically, because in the obesity there can be fluctuation in the level of the cortisol. Because of obesity, the effect on the cortisol level. So for those things we have to recheck it. Many times it needs several times it needs rechecking of the hormones level. So we have to be very particular when we diagnose these hormonal syndromes. So this is all about the adrenal and the thyroid emergencies. If you have any doubt, you can ask me. Thank you.